Just doing. Good evening, everybody. How are we? Very excited to be welcoming you to our very first joint alumni event with the CEC Clinical Leadership Program and the ACI Graduate Certificate in Clinical Redesign. For those of you who don't know me, my name's Lee Kirkwood. I'm the Associate Director of Clinical Innovation, Redesign and Consumer Engagement at ACI, and very proud to say that I've been involved in running the redesign program for a number of years now, and very excited to have you here tonight. I'd like to start by acknowledging that we're meeting on Camaragal land for the Camaragal people of the Eora Nation, and pay my respects to elders past, present, and extend that respect to any people of Aboriginal heritage here today. My job is to do the housekeeping, so you've already seen the food, so that bit's done. Exits is through the green door here, or the sign where the green sign is. That will take us outside near Wendy Whiteley's garden. The bathrooms are through the foyer, just out the front here. Our phones, if we could have them turned to silent or off for this great talk that we're about to have tonight, that'd be great. Just a reminder that we are live streaming this event tonight, so we have some people at home watching, and we will be taking questions from people at home as well tonight. So they'll be texting in their questions. We have a Twitter hashtag, 2 Twitter hashtags for tonight, which are on the screen. Where about on the screen? There we go. So ACI CEC Alumni and Improvement Alumni. So feel free to tweet away. And if you need Wi-Fi to support that, the Wi-Fi password is on your table. So there is Wi-Fi available tonight. Finally, for those speakers, up here there has been consent for live streaming, so photographs will be taken through the night, and in your attendance by signing on you've agreed to have your photograph taken, but if you have any concerns about that, please come and let one of the organisers know, and we will endeavour to make sure your photos aren't shared. I'd like to introduce Raj Verma, who's our Acting Chief Executive at ACI, and Raj has been the sponsor of the ACI redesign program for the 10 years of its existence. So thanks, Raj.
Thanks, Lee, and good evening, everyone. It's great to be here. I'd also like to acknowledge that we're meeting on Aboriginal land and pay my respects to elders past and present. So it's great to be here. Congratulations to all the alumni for making your way back, and it's great for this event, which we've been talking about for a while, and a joint event between ACI and CEC, to bring you back all together and to hopefully start working towards some events where we can help you keep up to date with what's happening, but other events where we might network or problem solve or share ideas. So we're really open to those ideas, and we really want to hear from you about how you would like to connect. I'd also like to say hello to all the people on live streaming who are on the event, and let us know your questions via text. So both programs have been going for 10 years, so that's a significant achievement in health, where things tend to change very quickly. And if you look at all the other states in Australia who have at various times had some form of redesign program or improvement program that's come and gone within 2 or 3 years, to survive 10 years and still be going strong is a real achievement. And I think it goes to the value add that's coming from the program, and that value add comes from all of you and all of your colleagues who've graduated and delivered results and added value for the patients of the state. We both have a remit for our ongoing commitment to improvement, so we will continue to provide training both from the ACI and the CEC to people in the system to help develop those skills. For me, what's great is that there are so many smart people in our system, and when we see how much you can develop just by giving you the right tools and the right training, and to see how that develops. It's fabulous. So we really enjoy, and it's a privilege, certainly from ACI and I'm sure from CEC, to see how people develop and how they bring out new ideas, new thinking, and provide solutions to all sorts of problems right across our health system. So it's really great to be involved in helping people grow their knowledge and their skills in this area. It'd be good to just get a quick show of hands. So who's a graduate of the CEC program? Hands up. Graduate of the ACI program? And graduate of both. Have we got any? No one here tonight? You're not? Yeah, okay. 2. Excellent. So it's great, and I know there are some people who've done both, and it's fabulous, and I think they are people who've done both, so they're very complementary and different sets of skills that we're training. So we also are very aware of that and can keep connected in our program. So it's great that we can celebrate. So we've got some newsletters planned, and our first joint newsletter is coming out soon. We're also open to the idea of bringing alumni events to different sites. If you want to showcase something or share ideas with fellow alumni, that may be one way forward. So really do want to hear ideas about how we might connect you all up, share, learn from you. So, and we do want to think about networking ideas. So afterwards tonight, please try and meet up with some other people and see if there's common interest. But one idea maybe is that next time we hold some sort of speed dating type event where you can talk about your, not that sort of speed dating, but you might have similar skill sets or similar areas of interest that you can learn from each other, because there are a lot of graduates across both programs. So one of the things we do want to do, and this, it's great for the first event to be able to showcase someone who's an absolute international expert in this field. So we're very pleased to be able to welcome Peter Lachman tonight. He is a paediatrician by background and is the current CEO of ISQA, so the International Society of Quality in Healthcare. So we really are going right to the top. He's got an extensive experience as a clinician and as an international leader in quality improvement and safety. He was an improvement fellow at the Institute for Healthcare Improvement, the IHI, in 2005 at the Great Ormond Street Hospital, or GOSH, which I think is a great acronym, which is a paediatric hospital. He also worked at the Royal Free Hospital in London, specialising in the care of people with complex long-term illness. He's also been doing improvement work as the International Fellow at the Royal College of Physicians of Ireland, where he co-directs the Leadership and Quality Program to develop clinical leaders in quality improvement. He's also the co-founder and chair of the Paediatric International Patient Safety and Quality Community. So I'm sure we can all learn a lot from him, and please make him welcome.
Low battery, but it's working. Okay. Hi, everyone. Thanks, Raj, for the introduction. I can stand here. Let's get rid of this. Okay, that's the title I was asked to speak about, probably because it's the area we fail the most. Okay. Why does something work in this hospital and not in the next door hospital? Why does this work in one clinical area and not in the next? Okay, let's just get rid of this. Why does this not go into my belt? Which is another question. Okay, so that's the question we're going to try and answer, but I'm going to answer in a roundabout way, mainly because there's no easy answer to the question. So you have to wait till the end of the slides before I even address the question. So, I'm not even there. Tony Tate, I didn't know you were wrapping up. Did you know? There we are. Okay. So that's the title. So here is ISQA, just so you know, International Society. I kind of retired out of my clinical work to become a CEO. The organization is pretty small. We only employ 14 people. We have membership in 80 countries, and why it's very important for Australia, because the headquarters used to be in Melbourne, because some Australians decided to just put it together in 1984, 85, and so it was till 2008 it was based in Australia, so we've got lots of Australian members. And I've got 5 of them on my board. So it's very Australian-led. The last president was Cliff Hughes, and the next president, current president from Canada, and the next one is Jeffrey Braithwaite. So you can see a lot of Australian influence. We run this fellowship program, which some of you might have done. Anyone done on the fellowship program? Okay, we're about to review it and have a critical analysis of it, to revise it and so on. So your feedback will be very important for me. Wendy, if you give me the names, then I will get Pat to contact you. Pat O'Connor is working on that with me. We have external evaluation is the raison d'etre. So unfortunately, I was alive in 1985 when standards weren't even commonplace. There was no clinical governance. There was no concept of patient safety. Ivan Illich wrote in Medical Nemesis that we harm 15% of people. He didn't know that that was the right number. He just made it up, but he was correct in 1975. But there was no art. Don Obedian was only starting to write in the 1980s. And these guys got together, set up, can we have standards in healthcare? Now, of course, Codeman had done standards in the UK, US. But so that was the evaluation. We got them. This is something new. This is exciting. We're working in Africa with communities of practice. Can we spread? Now we're talking about spread. This is how can I spread across a continent? So these are leaders across we've got it there, about 20 countries. Mainly Southern Africa, you can see, because they're the strongest. And there's Nigeria. And there we've got Tunisia and those areas. So it's growing, and the next conference will be in Africa, so that's very important. And this is in South America. Actually, it's changed because I was there last month, and there's Paraguay there. They're not in, but Bolivia are now in. And Venezuela, as you know, is a mess. So they're going to take time to get in. But we're covering the whole continent. And this is about spreading learning. How can, when you do something in Argentina, can someone in Brazil or Colombia or Chile learn about it? That's spread. So we do that. So these last slides are all about spread, of how we're spreading around the world. And we have experts who help me spread. So I went with Paulo Souza from Portugal to Argentina. And I'm now going with Uma Cottigal to Colombia in 2 weeks' time to spread. So we take experts around. Jeffrey's going to, so I'm here on this as an expert, kind of expert. I'm only an expert because I got on the bus before you did. And that was in 2005 when I went to IHI. And I said, who's IHI when I was offered a fellowship? And who's Don Berwick? I didn't know because that was early days. But that was before the bus left the station. It was just as the 100,000 Lives campaign was going on, as they were ramping up. So I was very lucky. I was at IHI in the 100,000 Lives campaign. That was my year. So I learned about spread. Now, I'm going to base this on who was at the conference last week. Hello, anyone? Anyone else? Paul? So the conference last week was called, the theme was called Heads, Hearts, and Hands, weaving the fabric of quality together. Huh? You remember that? The two of the ones who went. Which we didn't realize was such a good thing because it's all about how do you spread. So I thought I'll base the talk tonight on the heads, the hearts, and the hands, which you need all together. So bear with me as I deal with the heads. The heads is what we think, and often that is what we do. It's logical to improve. We ask rational people rational questions to, ask doctors to wash their hands. Hand hygiene. That's a rational question for a highly intelligent person who then doesn't wash their hands or follow the hygiene. Of doctors, rational questions to write their scripts correctly, to hand over correctly. You're asking rational people. That's all head stuff. So that doesn't work. So you've got to go beyond it. So the heads. The first thing of the heads is that you can't continue doing the same. I'm very interested when I hear about service redesign, because to be really, really critical, while you're building big hospitals, you're not redesigning any services. You're just playing around on the edges, because you can't treat chronic disease in a hospital. You know, chronic disease, hospitals are for infectious diseases, for acute diseases. But chronic, you put an elderly person who's in their 70s in the hospital, or in their 80s, and you're putting them in a system that gives them pressure ulcers, falls, medication harm, and then you run projects to solve that. The problems we created because our design is wrong. Healthcare has been designed for the past, not for the future. So healthcare redesign is going to be quite radical, of changing the model that we have totally. But that requires changing the incentives, the way we paid, the way the politicians open new buildings. So it's very difficult. So we have to think radically different. I'm going to be quite controversial now because that's my job. The second part of the head is that you can't ask people to work harder. So this is my basis of all this teaching, all of yours, because if you're teaching Lean, Six Sigma, TQM, Model for Improvement, it's all from this man who's not an original thinker. He's a good synthesizer of thought. In profound knowledge was a synthesis of a lot of evidence of stuff that he managed to work together, and you have to know first what you do before you try your best. Trying your best is not good enough. But that's what we ask our doctors and nurses to do, to try their best to be safe. But that's not good enough. They don't know how. So Margaret Chan, the last person, am I okay in this thing? Yeah. Margaret Chan, the last person who led the World Bank before the current Tedros, said this: we know what to do, but we don't know how to scale it up. Basically, that's what she's saying. We know what to do, okay? What's the power of us to scale up and spread? It's very difficult because we know what to do. This is the reason why. I'll just choose one or two things. This is avoidable hospital admissions. That's the OECD average. Couldn't find this. Australia. Oh, the fourth worst was COPD and asthma of the OECD countries. Actually, I couldn't see Australia earlier. I looked outside, I thought there was somewhere there. So can you see the work you have to do? OCD, those are because your system's designed to put people with COPD in hospital. I'm running an COPD collaborative in Ireland to keep them out of hospital. And that costs money. And then you say you're underfunded. You see the problem. So I actually looked for an Australian slide, and this is the Australian one: preventable hospitalisation by category in New South Wales, just in case you think, oh, that's all the other states are doing it. Now we're in New South Wales, and as you can see, vaccine preventable are those, that's infectious diseases. There's the chronic conditions and acute conditions, and the total's up there. There's the vaccines. The total's up there. That's 2,200 per 100,000 population. Preventable. So what's the population? Oh, Elizabeth told me 8 million. Someone was the maths tell me how many people per year that is. Preventable just for these conditions. And so what we do when we do this, we build another hospital. More beds. That's what we do. The people are waiting in the waiting rooms, in the ED, can't get in. So just like in a highway, when you have a traffic jam, what you do, you build another lane. So instead of 4 lanes of traffic jam, you've got 5 lanes of traffic jam, because you haven't solved the problem by redesigning transport. And that's what we do in healthcare. These are avoidable admissions. Okay. The people who shouldn't be in the hospital that are, and we even haven't talked about the elderly there. Can you see the problem? So redesign really means rethinking the whole way we do healthcare, which is a challenge because we can't do it. So we need total redesign at low cost. Okay, total redesign at low cost, not at high cost. I'm a doctor, and the one of the most important word I learned at medical school was the word more. How are we going to solve it? More nurses. How are we going to solve more money? More beds, more equipment. That's what I learned. Never say less. Okay. And I'm saying there is no more. There really is no more. So we have to think differently. And that's what the head's got to do. The head's got to think differently, because the heart always says more, more, more. So here's one way. This is from the WHO. So let's have a look at it. Integrate care. So how do you tie up your GPs, your community clinics, and your hospitals to prevent people from going into hospital, and with social care and education? As a pediatrician, I add education and social care, and I add housing, and I add transport and roads, all the different agencies that prevent people in. Because we actually don't work in healthcare. We work in disease management. If you're in a hospital, you don't work in healthcare. The euphemism, it's called healthcare. If you're teaching disease. If you work in healthcare, you'll be in public health, out in the community, preventing people from coming in. So we've got to tie up the dots, and this is the way to do it from the health. So this is an image from the World Health Organization. They run in, this is the year of primary health care, the year of 40 years of Alma Ata. And Alma Ata was actually celebrated 3 weeks ago, but in 3 weeks' time, they're going to have a big celebration in Kazakhstan. And you can see it's about empowerment, both of the patients and of the provider. Make differently. Coordination, accountability, and that's the most problem. Reorienting, that's okay. Now, there's an article there I put there from Ashish Jha, because this is also the year of the launch of the Sustainable Goals for universal health coverage. Do you have universal health coverage here in Australia? Free health care for all, for everyone equally, with high quality for everyone. No. They're saying universal health coverage has been universal, high quality and safe health coverage, not universal health coverage. And so when I look in the UK where we do have universal health coverage. Every citizen has health coverage, but it's not equitable. Depends where you live and what you get, what quality you get. And the quality is very variable across the country. So that is where we've got to go. So this integrated care is our challenge. But how do we integrate care when we build in hospitals? Bigger and bigger palaces. Because you've got to fill them with patients. Otherwise, what the doctor's going to do? And we say we build more hospitals, we have less hospital beds. But we've got to really rethink what we need. So that's the thing. So that's the one. This is the where it comes from. This is just, I'm giving you some reference because you need to do some reading. This is a WHO book on healthcare policy, just published last year. Sheila Leatherman was one of the co-authors with Sham Syed. And it gives policy, what governments, what the citizens, what you need to do. Very important read. The World Health Organization has gone on a mission now to look at quality in healthcare. The second one, so there it is, actually the 8 elements. I'll just stand here. Define and align policies and priorities, goal setting, this is how a policy is. Selection of control indicators, situation analysis. So if you wanted to speak to your, I should have given this to Elizabeth when I saw her, but if you want to speak to your policy makers, here's a manual for them. It's really aimed at lower middle income countries who've got nothing, not really aimed here, but it's a litmus test. You can say, we should have all of these because we're nothing in my country. We should be able to do all of this. This is in the book, it's showing what they would like for primary health care. There's the primary healthcare team, self-help groups, liaison, social services, specialized prevention services, the NGOs helping, diagnostic services, which could be in the community too, because nowadays I can take out my mobile phone, which is the size of Heather's phone, I mean my ultrasound machine, or my cardio, or my ultrasound, and I can just do an ultrasound. I can put it on here. I can do an echo, just like this. Is it as good as the one I have in the hospital? No, but it's good enough. And you see the thing, it's not as good as the gold standard, but you don't need the gold standard, you just need good enough. But what's that going to do? It's going to close down a lot of centers. Can you see the problem? But this is the area, there's a specialist care. You see, it's not as big as the center, which is primary care, where the people live. So this is the kind of image they want to do, to reorient care, where primary care is the center. And my experience over the years is that hospitals don't like giving up their power. Now I'm a community pediatrician. Well, actually, I started off as a community pediatrician. I worked as a hospital pediatrician, then I became a community pediatrician, neurodevelopmentalist, child protection, Then I went back into hospital care and became a hospital pediatrician. Then I went back into the community care, then I had put in both camps. And I was always fighting. The reason I had put in both camps, because that's the only way I could get the money for the community, is by being in the hospital, by being the medical director of the hospital, so I could redirect surreptitiously services to the community. So this year there's that report, and this year there were 3 reports I recommend. This is the editorial from the Lancet announcing the 3 reports. Here are the first 2 reports. This is the one delivering high quality services, how to. That's a very important read for you from the WHO, OECD, and World Bank. And Sheila's again the lead author on that with Shams, and that's very important. Crossing the global chasm, quality chasm. That's a problematical one. It's from the National Academy. Remember, we all write the Bible, crossing the quality chasm from 2001. We all quote it all the time. Now they've redone it for lower middle income countries, and lo and behold, they find incredible gaps. And they make a number of recommendations to apply what they apply in America, systems theory, all that stuff you know about in the lower middle income countries, even though it hasn't worked in America. So it's a very interesting read. They show a lot of things that aren't working, a lot of things that are working, and then lots of good lessons from it, but there are also lots of issues with it. Is it real? And just to add it, the next one came out last week. Oh, sorry, before I get there. Just to say, in the WHO one, they give the actions, call to actions. This is what the system must do. Okay, finance correctly, IT, and so on. Those are the call to action. So this is the call for the system. So you, the system, so this is what you have to do. And it's a nice page, and I explain all these things that a system should do. And this applies to upper and lower income countries. It doesn't really matter where you are. The call to action, develop financial mechanism systems that are appropriate. Ours are not, because they reward bad behavior, not good behavior. Now, the value streaming stuff is aimed toward good behavior, but you're still funding big hospitals, so that's bad behavior. Can you see? Because it's not really bad behavior, but that's a design. So, call to governments, health systems, providers, and citizens. You call them consumers. Okay. So that's the call to action. So it's really worthwhile reading this document if you're interested in equality, because you see what the World Health movements are going to be. Because one of the things you were asking about is spread and sustainability. these are the ways that we're doing spread and sustainability at the high level. Because this is aimed at ministers. Remember, anything the World Health does is not aimed at us, it's aimed at governments. Your government has to decide whether they accept these documents. That's what they have to do. Your federal government, not your local governments. This is the one that came out last week from from the Lancet, which found similar studies, similar issues. The Lancet Commission was working as well at the same time. These three big reports means that there's going to be a lot of activity worldwide within the Sustainable Development Goals to improve quality for those who need it most. So, the World Bank, this is now the World Bank's view, is that we spend a lot of money basically, but we still haven't worked how to prevent. So we face in the UK a crisis in pediatrics of obesity. In 30 years' time, we're going to face a crisis of diabetes in adult care. The answer is not to build new diabetes centers and more endocrinologists. The answer is to tackle the social issue of obesity, which is far more difficult. And you see what it is. Basically, to keep people happy and healthy. That's our challenge. And it's a challenge for all of you and for me. Most of what I've done in quality improvement has been working fixing broken systems in hospitals rather than saying how can we pull up at scale to improve the quality of health so that we don't have to do it. Politicians don't like that because that's a 20-year program and they're not going to be around for 20 years. The hospital takes 5 years to build and they're going to open it just before the next election. And they're the ones who fund him. So we've got to educate the politicians on how to do this. That's in their interest. Their legacy is on the future, not on present. And just to finish off on the heads, the Tokyo Declaration is where the ministers of, I don't know if your government went there, possibly they did, where they went, every year they go to some place, it was London, Bonn, and Tokyo, and they made this declaration at ministerial level. And the only reason why they do these kind of things is because the public are saying we want us to fix patient safety. The ministers only get involved in things that I'm being a bit harsh on them because some of them are altruistic and well-meaning, but they're always watching what the public wants, and their focus groups say they're worried about safety in the hospital, the quality of care. Because Google tells them, the public can see. Your consumers read Google, and they can look and see where the things are. And they read the newspapers, and the newspapers like telling things when they're bad. They never tell us what the good things are. So that's what the consumers read. So really, the head tells me we have to do things differently. Okay, but how? So this is one of the networks. I'm talking about spread and sustainability. So this actually slide should have been at the end, but I wanted to keep it on the head side. You could all join this global network. You just click onto WHO Global Patient Safety Network and you go into a site and suddenly you can join and you're part of a global discussion group on patient safety, how to solve patient safety on a global thing. It's very easy to join. You just put your ease in and you join in and the discussions and you get interesting stuff, how they're doing around the world. That's spread. So that's how we're doing some spread. And you can look at these. I don't know, does anyone know about this medication without harm campaign? Who knows about it? Very few. Why? You're the medication team. You should all know about it because this is the safety challenge number 3. Number 1 was clean care, that's hygiene. Number 2 was safe surgery, and now it's medication challenge. A load of stuff that you could use. And if you've got things, you should be posting them. You should be sharing your stuff. If you've got any good programs on the website ahead, one before, because that's going to make a big difference. People want to know how do we solve problems, and you have to share. And then I put this in the heads. Why I put this in the heads? Our accreditation, because we do a lot of accreditation. We accredit a lot of Australian bodies. We accredit a lot of organisations, because those are the standards, and that's a very head stuff. That's all about heads. Do you meet standards? It's not in the heart, and not in the hands, because that comes next. So these are the kind of things you have to do. So for the heads, okay, the heads, there are challenges, there are design problems, there are safety problems and quality problems and equity problems, and this is an international problem. It's not an Australian problem. Okay, so every time things bad, you can read these documents. You're not as bad as you think you are. You're much better. You're actually quite good in most things. So let's go on to the hearts. So Deming basically, in his 14 principles, spoke about the heart a lot, less than the heads. Give workers the pride in their work, and they will have good outcomes. You don't need inspection. Just give them pride at work. And you know that in healthcare, if you do that with doctors and nurses, they will do a good job. Give them the pride. Inspection has never been shown to improve anything, except for the time they're doing the inspection. If you ever have to prepare for your accreditation or your inspection, then you've got a problem. You should never have to prepare for your inspection. You should always be ready. Always be ready. Lloyd Provost said to me, it should be the situation where you say, bring it on. Walk in any time of the day. We are better than you want to be. And if you find something we don't know, we welcome it. We want you to tell us where we haven't met it, because we're constantly improving, we're constantly looking. And that requires the heart, the change of mind. So this is what I'm really trying to get at. I don't work in the healthcare business. I work in the safety business. I'm not a doctor who cares for patients. I'm a doctor who keeps patients safe in a complex environment. I also happen to treat them. When I get on the plane from Dublin to London, I do that every week. The pilot doesn't tell me I'm here to fly you to Dublin as his first thing on BA. They don't. They say, hi, I'm the pilot, my name is, I'm here to keep you safe. I happen to be flying you to Dublin. I should know, I'm on the plane, I've got a ticket, I know where I'm going. How many of you go to work to keep the patient safe or to treat the patients as a primary job? So the doctors in the room, do you go to treat, make diagnoses, treat patients, or do you go to keep patients safe as your primary role? It's not a rhetorical question. Does anyone go primarily to keep patients safe? What kind of doctor are you? Sorry? Anesthetist. Okay, anesthetists are slightly different. But, have you had human factors training? Yeah. You have. How many people have had human factors training in this room? How many other doctors had human factors training? You're a doctor, so you can put your hand up. 1, 2. And how many of the other doctors have not had human factors training? Okay. So basically what I'm saying is the majority of people haven't had the right training and therefore would not know how. They try their best to keep the patient safe, but they don't know how. They haven't been trained. I'll give an example. Is if I don't want to embarrass one of the doctors, so I embarrass Hala. We did the team talk. Who's the sickest patient in the hospital today? No? Does Hala know? Or what's the reliability of patients getting 100% care? What's the reliability? So let's have a look. Worldwide, we have powerful methodologies. We know what works. Across contexts, we know. We have expertise. We have all of that. Yet, we cannot spread. We know what to do. I know how to prevent a pressure ulcer. I've had 80% reduction across a collaborative. I know how to improve strokes within 30 minutes of having the stroke. I know I've got a methodology, I work it. But spreading it and making it generalizable, that is tough. Well, one of the reasons is that we don't have these habits. So people have seen this a number of times today. This is from Bill Lucas from the Health Foundation, it's downloadable. We do not have the habits of improvers. So you've all been on courses, and this is your homework, is to take a photo of this and self-analyze yourselves. I'm not really interested in analyzing you. How many of these do I really have, and how will I demonstrate it? How do I manage conflict? Okay. How am I creative? How am I empathetic? Do I understand systems? Do I co-produce? Do I tell people what to do or ask them how to solve it themselves? Do I come with solutions, or do I create solutions with the clinical teams I'm working with? You see? So this is about the habits of the improver, and you've been on you've been on courses, you should all have all these habits. And for those who teach on the courses, do our courses create these kind of people? That's for them to self-analyze. And if you've been on both, has two of them managed me to get all of these? Has a double dose helped me? Can you see? This is a wonderful document about the habits that you have to be an improver. And for those who are in medical schools or nursing colleges, are we turning out doctors and nurses who have these habits? They don't have to have all, but they have to know how to do it. So I'm not going to spend much time on it because there's a lot to go on this. I could spend the whole day on it. But really, today I'm going to look about creativity. Okay? Are we creative in the way we get our solutions? I could spend on any one of these hours on which one. So this is self-analysis. It's very important for us to do because I do not expect you to have them all. Because I don't have them all. Sometimes I have more of one than the other. Because it's not, oh, I've got them all, I'm perfect. I learn all the time. I learn more by coming to Australia than I'm giving you, because I'm observing the whole time. I'm having critical analysis of what's going on. And I try to be creative. Even though Helen's seen this slide 3 times today, they've seen it in 3 different ways. So really the key thing about this hands and hearts is that it's not about the patient. It's about the provider and the patient. If you look after your providers, they will look after your consumers or patients. Because that's why they went into healthcare. But we don't look after our providers very well. So I don't believe in patient-centered care, consumer-centered care. I believe in person-centered care. And there's more than one person in this paradigm. So these are, for example, this comes from Helen Bevan. And how do you look at your staff? As an asset or with needs? So the assets focus on strengths. There you focus on deficiencies. So in a clinical team, when they're doing their huddles, what's our strengths today? What's our strengths today? That's very different of saying where are the issues. What have we done well rather than what went wrong? What went wrong comes after that. But what have we done well as on strengths? Relationships rather than fragmentation. To solve a problem, you have to get the microsystems to work together, give their talents and resources, dependencies, and there's the empowerment. Okay. And another way of looking at it is this one from Helen. The values to get people to act. in the heart. Urgency versus inertia. Okay? Anger. That things aren't right. You know, when you get a difficult consultant come in, throwing their toys out the cot and they're angry about it, boy, that's an opportunity to harness that anger. But we don't. Often we don't. Anger's good. It shows someone really wants something different, just doesn't know how, and channels in anger. Well, let's rechannel that anger in some constructive change, into critical thinking. That's where your habits come in. You can make a difference in inclusion versus isolation. So you want to get rid of these to overcome, and you want to use the change ideas as leaders. And this comes from Holnagel saying that we concentrate on that side, on this side, on things that go wrong. The clinical risk team has been all the time doing these case notes reviews and these RCAs. That's what you guys do. And every time we say, oh, communication must be better, the medical records must be better, they must hand over better, they must, time over time again, you get the same stories, and each time you apportion different responsibilities for each part. And what we do, we're going to have training, we're going to have education, we're going to give them points, we're going to give them this, and nothing changes because the next one comes. Same thing happens over again. And I used to do serious case reviews for child protection. Every time it said social services and healthcare must learn to talk to each other and respect each other. I never had one report that ever didn't say that. Didn't say that they were working perfectly. So you say, well, what are we doing these case reviews for? If we know that we're not going to do anything about the change. So Holnagel, they're actually in town in November. Holnagel, doing a course at Macquarie. I'm advertising for Jeffrey actually. They say, why don't those risk managers not be risk managers, but also be excellence managers? Studying what worked really well, to understand why did it work really well, rather than why it didn't. The positive versus the negative. That's building resilience. That's why in the huddles they do, well, the Children's Hospital today, they always start off, what have we done well since our last huddle? Because the next question is, did we harm anyone? So they've done the positive, then people feel more relaxed to give the negative because they've already had the praise. Humans love praise. They love affirmation. They love to be told they're doing well. And then they don't mind saying things didn't go well as well because they've already got their praise up. That's what they're talking about, the resilience engineering. It's a bit more complex what they talk about, but I'm trying to tell you that's a simple thing everyone could do straight away. I was going to show that, but I don't have time for videos today. And just to show I want to just put this in their hearts, because it could be in the heads, it could be in the hands, but this is from NUCA. It's really worthwhile looking at this site. The NUCA is the South Central in Alaska, and it's really good because I heard a new word is priority services, or your Aboriginal services. So Canada's got the same kind of problem as you. The First Nation people were really done hard by, and now they're trying reparation. How can we improve it? So NUCA is in Alaska, and this is where the services are owned and designed by the consumer. The doctors happen to work there. It's a wonderful system, and Doug Eby is the guy. So it's worthwhile having a look at this. And it's a really good way of doing it, especially if you design Aborigines, consult with them. So I like this one because he's not a partner of ours, but I know Doug well, and it's really interesting work on how to work with First Nations people. And the frontline staff need to own it. In Canada, they've got this whole frontline ownership, which is basically Deming stuff about frontline. It's nothing new. They just package this in itself. And this is the first of our partnerships. So as you know, one of the reasons I'm here is because CEC is part of a QI network, and the QI network has 5 or 6 members, I think 5. One is in New Zealand, Calcutta, 2 in Canada, one is British Columbia, and 1 in Brazil. And this is the kind of things they share. So this is what matters to you, program, they run. So I've been doing it, What Matters to You, which some of you have done, which I think don't do unless you really mean it. Most people do it as tokenism. They ask the patient what matters to you, then they carry on with the normal life. They've done their tuck, they tick it off. We've done what matters to you without changing the way they act. So it's shown at the Children's Hospital today how you can make a real difference with what matters to you, but only do it if it really matters to you. And also do it for your staff. But it has to really matter to the person who's asking, that they want to know what matters to you. And there's the improved culture. So they're very strong on that. So it's quite nicely to hear them speak on the network and a lot about culture stuff and so on. And these are brought in because I think these are great ideas for you to have done ones. You had Change Day, you've got Change Day. But the Academy of Fabulous stuff is quite amazing. Anyone can put up stuff that they've done well. That's fabulous. That's be fabulous. What's this telling to staff? When you're fabulous, put something up. When you think you've got a good program, put it up. What's that about? That's about spread. That's all about spread. This is about spreading good practice, but bottom up, not top down. It's a bottom up saying, we managed to do this. Spread it. And they're the Change Day. You know about Change Day. That's spreading, but I've got a problem with Change Day because it's razzmatazz and nothing changes. Only put something up if you really mean you're going to change. But the majority of them, nothing happens. But it's a good feel thing. It's a good, makes people feel good. So maybe that's okay. That's changed. Okay. And then choosing wisely. Do you have those in Australia? That's aimed really at the doctors and consumers. How do we get people to choose wisely? That's always run through the Royal Colleges. They won't go through anywhere else. So they want, because it's the professional bodies, their belief is that the professional bodies need to come up with what the choosing wisely is for your own country. So if they're working here, they'll be through the Royal Colleges or whichever Royal College, surgeons, pediatricians, physicians, so on. And that's another way to look at it. And we involved with that. We were actually, there's a choosing wisely meeting right now in Zurich. So the heart is the mind, and I gave you lots of ways to do it, but the main thing for the heart is what is the matter. Not what is the matter to the patient, but what matters to the clinician. That's what I want to improve first, and I'd also like you to do what matters to me. That comes from Marshall Ganz. What matters to me, what matters to you, what matters to both of us. Yes, we can do it together. Echoing to Obama. Finding what matters to the consumer. And that's, if you think about elections, I don't want to say Donald Trump's any good, but he worked out what matters to the voters. Hillary Clinton didn't. That's why he got elected. He worked out what matters. We might not like to hear what matters, but he worked out what matters to the voters. We've got to work out what matters to the doctors and nurses who provide care. I don't know any doctors or nurses who want to provide bad care. But I know a lot of doctors and nurses don't know how to provide good care, safe care, because they've never been taught it. I know a lot of them. They're trying hard, they're working hard, but they don't know how. And we've got to help them. But first on what matters to them. So if I want to pass something in an area where I have a lot of opposition, orthopedic surgeons maybe, they're not too bad, I want to find what matters to them. Obstetricians, I want to know what matters to them. If I wanted to get the surgeons and the anaesthetists to do the WHO checklist, I want to find out what matters to them first before I ask them to do something, because they've already got checklists. They just don't have a unified one. I want to find out what matters to you. My theatre lists start on time, don't start on time. Okay, we'll work on that if you help me on this, because this can actually help your theatre list start on time because we know what's going on. You see, finding what matters to you. So spread and generalizability is about finding what matters to the people you're asking to change. But our systems run collaboratives and so on because the health authority looks at those statistics and says you now have to have something on pressure ulcers, whether or not the teams want to have it or not, because they might have a bigger problem than the pressure ulcers. And you see, you've got to really think hard. So let's get on to the hands, the interesting stuff. Am I on the hands yet? Yeah, hands. So this is from Richard Boehmer. So this is a nice article you can get from the NEJM, and the high quality. So I actually took him. See, what I like is when I read these papers by Richard Boehmer, it was an NEJM, the PI thing, I read and said, that looks very similar to Duran. Because first thing in Duran is quality planning. So high-performing audience hospitals are planning the whole time. They're building the infrastructure. They're measuring, and they're learning. So how many from hospitals? How many from teaching hospitals? Hands up. How many from, hands up, high up, come on. Hands up from teaching hospitals. Keep them up if you're from learning hospitals. The difference between a teaching hospital and a learning hospital. A learning hospital doesn't need the CEC to do the RCA. A learning hospital is learning every day and continually improving. A teaching hospital is what we've got. Teaches people. So we really need to become learners in order to sustain, to move from teaching to learning, to admit we don't know when we have to, and to look and share for solutions. So the challenges we face is we have to know how to measure. This is very difficult because we measure too much. What are the measures we need? We have to look at quality from the eyes of the patient, not from ours, the consumer. We have to have a methodology. I don't care which methodology you use. I'm really not agnostic. I don't care. It all comes from Deming anyway, so I don't really care. Whichever vendor sells you the stuff. We have to learn how to scale up, and we have to move to prevention rather than cure. And I'm going to just look at this one. I said to the hospital today, what I would like the wards to do, all 24 wards, each of them to define what their harms are, or what their quality, and every day to measure that. Number of days since the last fall, number of days. If every ward is doing that, can you imagine what will happen? Not someone else managing and getting a monthly or quarterly report. Oh, you had so many falls last quarter. That's too bad. If someone falls today, I want to know someone's not going to fall tomorrow. You see, I want to know what are we doing. And that is at microsystem level, at frontline level, where they come in and say, safety is our business. I learned that in South Africa. Johnny will know, we trained in South Africa. At Red Cross, the nurse would say, we were very strict in those days, we were quite scared of them. They would say, on my ward, you wash your hands. On my ward, you do not have medication errors. On my ward, you do not, you take your bloods correctly, or you write hand over correctly. On my ward, there was standards that we as young doctors had to follow, because it wasn't our ward, we were visitors. Nowadays, there are no standards in that sense. We permit all of those. Poor hand washing, poor handover, poor hygiene, poor prescribing. I'm talking to the doctors in the room. We permit that. Therefore, we're promoting it. Because we can eliminate all of those four. If every day we measured it. So we've done lots of things in the UK to spread. One is spread very nice is something we call the druggle. It's a huddle with drugs, with the pharmacist, the trainees, and the consultant looking at every week's scripts, at the errors, moving to get zero harm in medication prescribing. Possible, but it has to be a priority at microsystem level. It's no use some minister saying to the secretary, who's saying to the CEC, who's saying to them, run a program on medication safety. The bottom line, it's the time the doctor writes the script makes a decision. I'm writing it 100% correct. No one can make the doctor do that unless there's a will to do that. And equity of care, of course, is something very difficult to achieve. How much in for time? 5 minutes? Okay, that's good. So this is the partnership. I wanted to show scale up and spread, so I'm going to use you as an example. This is our partnership. We have the Canadians, Clinical Excellence Commission, British Columbia, Calcutta, and Santa Catarina. Each have got strengths and weaknesses. Each have got solutions and problems. And my idea of generalizability and scale up worldwide was, what happens if I put these different places together and we mentor them? So I meet with them at midnight, my time, 6, 7 o'clock, Wendy, 6 or 7 o'clock here, because it's 10 o'clock in Auckland, and it's 4 o'clock in Brazil, and it's 2 o'clock in it's crazy. But I don't mind doing it because I'm learning the whole time, because I'm hearing things from the 4, 5 sites from totally different contexts, sharing and learning, what is generalizable, what is not generalizable. It's a really good experiment for me, and I think they've all signed up again for the 2nd year, so it is working. What do you think? Yeah, we just want to spread it. We want more of you to come onto it. We're just trying to work out this timing thing. I mean, I think actually that the Canadians must do it at midnight. I think we can get them to do it one time at midnight. I think we can do. Anyway, so this is an example. So this is an example that we'll share between the flags. Okay, that's a concept from here. We'll share that with them in Brazil. And actually, this is my proud moment. I did work in Mozambique. So I phoned, Harvey's not here. He told me he couldn't be here. So I phoned up Harvey. It wasn't Matt, it was Matt, I think, at that stage. I said, I need between the flags. They said, why? I said, at this hospital in Hausa Macamo, 5 patients are dying every week or every 2 weeks from within 24 hours of arrival on the ward. They want something, but there are only 2 nurses per 78 patients. So what they need is a tracker, not a trigger tool, because the nurses don't have time to count. So there it is, translated by these guys. I got permission from the CEC, and I'm spreading now. Now I'm doing spread and generalizability, in action. There it's done in Portuguese, they did it. There's Nelson, and that's Jonas, who's my man from the embassy. He knows everything, introduced to everyone, and he's the Mr. Oil, through the system. And Nelson's the head of medicine. Within 3 months, death rate had halved by introducing this. Context, the paper was so thin. They said, we can only get thin paper here, and we can't get color cartridges, and how are we going to get the red? The red looked like a sepia kind of thing, and the yellow was hardly seen. So don't worry, at ISQA, we were printing our programs for the conference next year. We'll print you all your 5,000. How do we get 5,000 of these? We go to the Irish embassy and say, send it in your diplomatic bag to Ireland, 5,000 between the flags that are now at this hospital, which is decreasing the death rate. So thank you, CEC, because you have saved 8 to 10 people a month for the last 6 months. That is 8 to 10 families of a father or mother, thanks to this. So thank you very much for giving me this. It was really amazing. But that's great spread. So can you see spread and scale up? That you wouldn't even imagine that in Mozambique. And my aim is, I haven't been in touch with them for 6 months, but they haven't come back to me, but I've got them on WhatsApp. That's how I do it. I know on WhatsApp. I'm going to tell them I spoke here on the WhatsApp, and I'm also, so if someone, the photographer, can send me that photograph of that up there, then I'll send it to these guys. And you know what, that's going to boost them to do it better. Treat that way. Because this is amazing. That's all they're doing. They're using between the flags. Not exactly like you want to do, but in their own context. Okay, it's an amazing story. So that's one of the things that this partnership is doing. So I want to thank you guys for that. In Tuscany, this is another one. We've got a partnership with them, a World Health Organization Center. They're going to run one of our conferences, learning from them how we could do this. They were supposed to be in a partnership, but they've said to me, 1 a.m. is not a good time for them because 12 p.m. for me, 12 a.m. is me, 1 a.m. is them. They're not a good time for them to be part of it. So I put them there because I'd love them to be in this, but we can't get the timing right. This is from the Improvement Journey from Santa Catalina, showing that they go, how they've gone up, and they've been sharing their experience there. And this is an example of results of the hospital-acquired infections. By 50% reduction, sharing with us how they did it in the context of Brazil. Really amazing stuff. And this I just put in Scotland. They're not part of it, but I think I'm going to ask them maybe to join us another one because they've done a lot of work of decreasing, as an institutional member of ISQA. And there we go. Again, this lot, I didn't need between the flags, but I used some other CEC stuff for them. And these are the guys in this Mabalani hospital. And you can see my eclectic way of measurement. I say, do it in as many ways as you can, saving the same data, because someone might see something different in a different way we do it. So although I teach run charts and run, that's why I teach those two, that one and that one. If they want to use bar charts for them, I'm saying, you can use it, but you must use the others. And you can use the old way because it takes time to convert into the new way. But that's very proud of that improvement board. They had nothing before I started there. The challenge is to make it stick. So this is the thing. We're like a galaxy. There are lots of bright stars of excellence. Lots of bright stars, but they're not linked. We have to map those out. In your state, you have to map out where the stars of excellence are, because you want them to shine out. So last week, so this is from a tweet from Helen Bevan, and the only reason I know she tweeted because last week the Health Foundation published a document which I'm going to show you now on spread. So that's very good news. They did it just before I'm coming here. But our program called SAFE, Situation for Awareness for Everyone, was one of the studies in the SAFE program. They want to know how did we do our spread, and I'll show you how we did in a second. So Helen tweeted this. Now this is the traditional IHI model that they had, which they said doesn't work. You see, there's pilot project rolling out, and then the collaborative ends and you're back to there again. How many of you done collaboratives and after a year you go back and you have regression to the mean? Huh? All of you done that, huh? So that model doesn't work. So we've got to think differently. So this is the new model, and here's the so you can go to the Health Foundation there, spread challenge, published last week for my benefit. I know that's coming out any time, but you can get it. And there you have simple, replacement drugs, surgical improvement, SMS reminders, difficult, complex. So what they're saying is that you have to know what to do for your kind of program. You can't use that one methodology. So you have to think harder. So that's the message over there. The second one is the innovation cycle. So those who did innovation, there's the problem, definition, concept, prototype, demonstrator, mass production. How do you get to the spread? So this is very important, the testing and revision. The people, just to say, the people who are the improvers are not the spreaders. They're two different professions. People who do the pilot study, the first collaborative, are not the best people to spread. Their skills are getting people going, not in spreading. So you've got to have spread experts who understand the new methodologies. So when we spread, so this is the kind of thing. So this is the traditional way you get for the innovators, early adopters, middle majority, late majority, laggards, okay? So what they do in this book, they turn it on its side, the innovator team, and then you get not early adopters, but co-innovators. They're innovating as you as well, and you're building up, they're the early adopters, and they go up. They turn it on its side as co-innovation. So this is how we worked in the SAFE project. I handpicked the first 12. 6 children's hospitals, 6 district general hospitals. Phoned up the medical directors, would you like to be in or out? So when I was speaking to Liverpool, I said, Manchester's in, yes, we'll be in. I was speaking to Manchester, Liverpool's in, yes, we'll be in. Speaking to Sheffield, yes, we'll be in. No, I used that kind of technique. You know, your neighbouring hospital's in, yeah, we'll come in. But the neighbouring hospital, they're in now because people don't want to be left out. And in London, we had 6. And then, of course, we had the normal bell curve of who did well and who didn't do well across the 6 months. Actually, we did very well. It was co-production. I took a safer situation awareness for everyone, and we've done it here they call it Team Talk. And what we did is we chose 6 hospitals, general hospitals, and 6 children's hospitals, all very different. And then we had the evaluation team embedded within our work. So I had realistic evaluation. Every month I was told how we were doing. They were recording sessions and saying this, we see this. They wouldn't tell me where and who and what, they'd give me the themes. So I could constantly change. And then when I go back, and then the other thing we did in the spread is, as a project lead and the program manager, Darren and I went to visit every site. And we were vectors. So just like I got people involved, would go to the one site and said, oh yeah, you know, they're trying this at Sheffield. And I would go to Liverpool, you know, they're trying this at Manchester. Well, how about you trying it? So I've been a vector in between every 2 monthly sessions. Not calls, visiting. What happens, people know I'm coming, so they know they have to improve. So I'm going to ask them questions, but not critical questions. So that was a key thing we changed to the breakthrough methodology. We became vectors, add vectors in. Then they became vectors themselves, so they became co-innovators. I didn't go with a package. I said, you know, I've got a theory of this I did in Cincinnati, maybe it'll work here, we've got to make it English, Here, I'm working with Annette Bartley, who started, she was an IHI Fellow the year after I was, and she did it for the first session, but then she got very ill. And Annette and I worked very closely together, so I worked with Annette on this. So Annette would teach a methodology, and I'd show, you know, can we do this? Well, I don't know what to do. We don't know what the answer is. You got to do the huddle. We're telling you to do the huddle, but we're not telling you how to do it. You tell us how you want to do it. I was spreading a concept, and they were co-producing. So rather than doing the traditional breakthrough methodology of spread, in which we came in with the solution and the bundles and said, this is what you're going to do, we said, we think this is what you want to do. Help us do it. And they were very much co-innovators, rather than, that's the first 12. Then we present, now the spread model, we only had money for 12, for 2 years, that's what the Health Foundation does. It was a lot of money, but it was only for 2 years. So what we did then is we went to the college meeting, and we had, all of them had posters of what they'd done in the first year, and we hired a small room, and Johnny, you were there that year? Johnny was my guest speaker. I brought Johnny across. They all came to see Johnny. And what happened was, at that meeting, we presented the stuff, and the standing room only. The other technique is we have a room smaller than we need, so that it's standing room only. And you know what, people, the English, they love to stand in queues. They see a queue, they want to stand in, and they were fighting to get in to hear Johnny. And then what happened really, really what happened, they came up after the 4 presentations. We chose 2 general and 4 presentations. People came up, how can we do it? How can we do it? So we said, we're not spreading. When people got a scarce resource, what do people want? More of the scarce resource. So then we sent out an advert. We said, okay, Darren looked at the budget and said, we'll find a way of doing it. So we changed the model. We sent an advert, and 16 applied in competition to get 8 places, so we took all 16. And now we had wave 2 of 8 and 8, and we changed the model of how we did it. Instead of giving them 6 sessions, we gave them 3 sessions. But now we knew more or less what we're going to do, and when we went to them, and Helen, did you come to some of those? Helen came to some of those as well, and what we did is now we're working with the second wave, which was even quicker, because we knew what to do from the first wave. We cut out all the nonsense. And we said, we think this works. But we still did the visits. So they got 3 sessions. And then when the money came to, in the second and third waves were the better waves. Then wave 4, what we did, we gave them 1 day. And we buddied them up with hospitals around them. So each hospital had to have buddies from the first 28. So then we got 50. Now the money has definitely run out, but I think they'll give us more money. But now in Ireland, I suddenly got more money a few weeks ago to do it in Ireland. So next week, or the week after next, we started 15 hospitals in Ireland. How am I going to do it? I've changed the teaching. I know what the method is, but in this program of situational awareness, I'm teaching them storytelling. The first day, it's about how to listen and how to tell stories. Because when I go to the team talks today, oh, by the way, I came to Sydney 2 years ago and did it with them, and came back now, and it's working. They've got a few things to fix it, things to add, which I've learned in the last 2 years, to give some advice, but they're doing the team talk. It's a long-term project to change culture, but they're using language they never used before. They're meeting in a way they never met before. They're talking about safety in a way they never met before. Have they cracked it? No, because if they cracked it, then they'd have a problem because they haven't cracked it. It takes years. But eventually, they'll say, this is the way we do it here. And there was an executive team talk today. There was a team talk for the hospital. And I went to all the 2 other team talks where they're doing things they never did before. We call it safe huddles. They call it team talk. Doesn't matter. They do it a little differently from somewhere else. Doesn't matter. The aim is the same. I'm constantly learning how to do it. I'm spreading. And we're going to do it in Argentina in September, because the concept's so good. But I never tell people how to do it when I spread. Generalizability, it all depends on context. So Helen Bevan talked about what I've just had tonight with you, what you've got right now, loose ties and strong ties. So Hala and Paul have a stronger tie because they work in the same institution. All of you work in different ends, but you're part of a network now, you've got loose ties. When we were at a conference last week, loads of loose ties. And loose ties, you get great ideas from the loose ties. So that's what this is about. Great ideas, loose ties. Okay, they don't have to be strong. So you really need to look at this. But you need to think about context. The latest research about generalizability is context. I was fortunate enough to spend some time with Rashad Massoud and a whole lot of people at Salzburg. Yeah, I've got 1 minute to go, Donnie. Third last slide. Anyway, so we've got to think of context, and in the place where Sound of Music was shot, the wedding scene, they've got a schloss or castle, we were there. And this came out about context. You can download this from the ISCA website on context and generalizability. And this is the final slide, I think, but one. Context is in the middle. When you spread and want to sustain, do what I did with the SAFE program. You don't tell them what to do, you teach the principles and say, how will it work where you work? Can you work it out yourselves? Co-production, sharing, and learning together. I hope we can work together. Thanks very much. Are there questions, Johnny, or I run over time?
Thank you, Peter. One question.
You need a mic, Johnny, because they're on the...
Any questions from the audience? There's also questions available for live stream.
We're about to get the number up.
0491 213 154. Please donate now. Flood Farmers Relief Appeal.
Sorry.
While that's coming up, any questions in the audience? Peter, if you'd done one thing differently in your QI journey, what would that be?
What's that?
One thing differently that you would have done in your career in the QI?
One thing I would have done?
Differently. I didn't say it'd be an easy question.
Yeah. I've been very lucky in my QI journey. I mean, particularly lucky. I would have started earlier. I was a medical manager since 1994, stumbling in the dark. But I did start early in 2005. But after I'd been managing a service where there turned out to be 10 maternal deaths in that service. So I just wish I'd started earlier. But being differently is also also trying to learn. I'll give you a very good example. That one with those between the flags. What I didn't do there is I didn't visit the place in the first instance to look at what the context was. So I did a lot of projects without looking at context. And a lot of projects we try to spread in Great Ormond Street without really accepting that the context is different and being doctrinaire. So I would do different. That's what I would do always, is say, and the SAFE program's taught me that. Context is what you deal out, and they'll do it, but in their way.
Questions? Don't be shy.
No, there's another one over there.
Oh, hold on, let me get the mic.
Thanks. I was just wondering, Peter, you mentioned about building resilience and training as part of our training as improvers, and challenging us to look at the way that the human side of the improvers. And I've been reading a lot on positive psychology and building resilience, and thinking about how we can implement that into training the improvers.
Yeah.
Have you seen any examples?
Yeah, so one of the things is I run on diploma 15 and 16 at the College of Physicians, run to 2 diplomas a year, clinical teams. So your equivalent, the HSC, pundit, so it's pundit, but we took a view that doctors won't want to go to work something in the health department, which they hate and complain about, but they come to their professional college. And so we have clinical teams on up to 15. And what we teach them quite simply from the start, we say 5% is the tools we teach you, 95% is the skills we teach you about your heart. 95, so we've got a big picture of a heart and a brain, 5%, small picture of the brain and big heart. And then we have leadership training for them embedded in the improvement training. So what we're saying from the start of the clinical teams is that the most important part of being an improver is understanding the person who you want to improve. And that is the skill. So now I know that that's the most important part. That's the heart. The head and the hands, the head is the what, the heart is the why, and the hands are the how. That's another way of looking at it. And there's a lot of research on the what, why, how. Saying that you can have the best research, you can have the best evidence, but if you haven't got to the heart of it, the intrinsic values. So I teach now, and is coming out evidence on this, that if you really teach the improvers to understand the intrinsic value rather than the extrinsic, which is easier, better for patients. But what's better for the doctor and the nurse? Better for patients, not good enough. So there are studies coming out, but those hard skills we call soft skills. And I say that those are the hard skills. Yet in English, as I said earlier today, that's another one. We reverse near misses, near hits, near misses, hard skills, soft skills. Now these are really the hard skills. The soft skills are the technical skills. The hard skills are the heart. That's more difficult.
Other questions? All right, do you want to read it out?
Good, someone's listening. They're out there. Hello.
So this one is from Lorraine, and Lorraine asks, how can we influence our politicians and senior decision makers to switch their rhetoric from healthcare being hospital care to the broader agenda of care in community?
I think that, that's difficult because hospitals politicians like buildings. But I think that starts I would start, I'm going to speak as a doctor. Now, as a doctor, I have a responsibility. And this is where it must come from the Royal Colleges and the universities to start thinking differently, because they're training. Who would close a hospital if you're training hundreds of doctors to go into hospitals? Training the training system. So really what we have to do with the politicians is, politicians are fairly reasonable. So we need to speak with the consumers. What's important for them? We need to start educating the consumers that a hospital is not the answer. High quality care in the community is the answer. Then the consumers ask the local MP, what are you going to give? We're going to build a new hospital, but we hear that high quality care, here's the evidence. Politicians want votes. They listen to consumers. So I'd go through the consumer, get the consumer groups. Now the problem with the consumer groups is that they're addicted to hospitals in many cases, because we as doctors have made them addicted. How do we do that? I'm not going to use just a case. Great Ormond Street. We send a patient to Great Ormond Street and they say, what have we done at that community hospital? You send a patient from the GP to the ED or to the hospital, and the doctor in the hospital says, what's your GP done? We denigrate the services. So we in the hospital have got a high responsibility for the current situation, because we are sending the message to our consumers that the only place they can get high quality care is in the children's hospital or the big hospital in Sydney, and not in the local hospital. That's the message we send. And then we pay the people in the local hospital not enough to make it as good as it should be, and we don't support them. So we really, I think as doctors, we've got a responsibility to change our mindset. That will help change it. In England, it's quite interesting. They're very sentimental about hospitals. No politician will close down their own hospital in their own area. Not because so much of the hospital being a healthcare facility, but the hospital being the major employer in that area, 3,000 to 5,000 jobs. Close the hospital, it's not about the services you can provide. So Lewisham is a very good example. They wanted to amalgamate the hospitals. Local MPs had a major fit. It's 5,000 jobs in our area going to go. That's 5,000 jobs, 300 families, 400 families with no jobs or more, no jobs. So healthcare then is a financial issue. Even when Mid Staffordshire happened, they objected to closing Mid Staffordshire because of the jobs. I worked in Lincolnshire. The pediatrics hadn't been safe. Beverly Allitt had been there. It wasn't safe. There wasn't enough patients. There were more doctors and nurses than patients. I said, close it down. Local MP, no way. Close down pediatrics, and ONG closes down, ONG closes down, and A&E closes down, hospital closes down. 2,000 jobs in this town go. Not about healthcare, but we don't talk about it, but that's really what they're... So we've really got to educate people, saying we can employ people in different ways in the community to provide services better. You see the whole thing. So we have a responsibility for the politicians to learn from us and to educate the consumers.
There's time for one more question. We just hit 8 o'clock.
Two, you've got two.
We got two. All right, let's do two.
We'll have two. We'll have two quick ones. I'll answer briefly.
All right. At the beginning, you mentioned it'd be good to see government partner together because it's not just healthcare, but it's also transport, for example. Just happen to work for transport now. I was wondering, are there a good example that you've come across where government work together? Well, that's a short
Very good. I don't know many in which the government departments all collaborate, except in Scotland, where they've got a program called Early Years, and they do announce in Cincinnati as well. So in early years, they want to increase. Scotland's got very bad outcomes for long-term obesity, and so what they're doing is working with education, housing, health, social care, all together learning the model for improvements, all doing it together. So that's a very good program. And Umakotikal told me of one in Cincinnati they're doing now based on that. And there are some very good programs in India. You know, those Nuka's one where they're combining them, but those are the ones you can do. Okay, last one.
My question is just about helping medical staff to develop the skill set that they need for improvement.
Sorry, could you put the mic closer? Yeah.
Sorry.
Yeah.
And have you considered lobbying the medical colleges, rural colleges, to include improvement skills within their curriculum?
So I work for the Royal College of Physicians as the international lead, and I'm running programs with that college, which is probably the leader. And we had a meeting of all the Royal Colleges, run by John Dean, a friend of mine, who's the College of Physicians. In our college, I also work for the College of Pediatrics, so besides ISQA. So I actually work for two colleges. The College of Physicians in Ireland is way ahead of everyone else. So every trainee gets an hour, every senior trainee gets a day of quality improvement training. I have 5 scholars who take time out, who I'm training. I had 1, then 3, then 5. Next year is 7, then 10, and scale up. That's the scale up of model. That's right. 1, 3, 5, 10, scale up. Sometime after 7, they scale up. So I'm scaling up there, showing how you can do it. We have programs called QI in Action for anyone in healthcare. QI in Action, the diploma, the patient safety diploma. We have all these kind of things that are going in that college. And the College of Pediatrics, and by contrast, struggle. I've got things there. I'm now in the meeting. Johnny's been to a meeting. Before, we wouldn't get it. Now we have more in the meeting, but they're a bit slower than the College of Physicians. Anesthetists and surgeons, they're getting human factors involved because it's more for their roles better. So it's the universities I have a problem with. So we've created an undergraduate training program for ISQA to sell to universities, because universities just have no expertise in quality and safety. And it's a scandal that a medical student comes out without any training in patient safety and quality of any sort. It's an absolute scandal in 2018. And we need to take that up with our medical schools. And the way you can do it is by saying we're not going to employ these doctors unless they've had the right training. Just as like they've got to have anatomy, we've got to train them. So it's got to become carrot and sticks. Thanks.
On that note, we might draw that questions to a close. Just a few remarks from myself. For those of you who don't know me, my name's Johnny Tates. I'm Director of Paediatric Safety at the Clinical Excellence Commission. Peter and I met, as I always say, when I was a 5th-year medical student at the Children's Hospital in Cape Town. I was petrified of him in those days. Absolutely freaked out.
Still is.
I still am. I've just got a bit older. On behalf of our Chief Executive, Carrie Ma, and our Head of our Quality Academy, Alison Starr, and Wendy Jamison, who runs the Quality Academy, and all the folks at ACI, I want to thank you, Peter. This has been an outstanding presentation. Peter never fails to deliver. I've been very lucky. I've been in QI for just about the same time as Peter, travelled and spoken and listened internationally. And I put Peter in my top 2 of all the people that I've heard. Peter Lachman and Steve Muthing from Cincinnati. You don't get better speakers. Okay, so this has been an absolute privilege for all of us today. And I know you've been working pretty hard the last 2 days, and so we appreciate you taking some time to speak to us. I think it's been an absolutely fantastic presentation, and it's been a real privilege. Every time, and I've heard Peter more times than I can recall. My kids get very cross with me when Peter's in town. They say it steals all my time. My son was texting me and said, please tell Peter, so Ryan says hi. So it's been an absolutely wonderful presentation. I want you to join me in thanking Peter for giving his time.
Thank you. My reward is a day in Dubbo and a day in Broken Hill.
He lost the lottery. Final thing.
Which is actually, no, seriously, because they might be out there. So I'm looking forward to see you. But that's the importance of going to the people.
Yes.
In the context.
Alumni event, please fill in your form so we can get some feedback on tonight's session. I'm sure it'll be excellent.
Thank you.